today's talk, I've made it to target towards a general audience and with some brief review of some of the guidelines that I hope can be helpful for some of the junior trainees on the call in their room for them to think about when they see a patient with dilated cardiomyopathy. All right. That being said, I have no conflicts of interest. And today, the objectives are the following: to review briefly the epidemiology of dilated cardiomyopathy, to discuss a framework and approach to echo assessment in DCM, and to briefly review, selected chamber quantification guidelines and review echo findings that can be associated in DCM, and briefly discuss what future applications of TTE and various other echo techniques in DCM. So what is the definition of dilated cardiomyopathy? Well, as for the American Heart Association, it's a spectrum of heterogeneous cardiomyopathies that are characterized by ventricular dilatation and depressed myocardial performance in the absence of hypertension, valvular congenital, or ischemic heart disease. Most of this is referring to LV pathology, and this is the focus of today. So we won't dwell in too much of RV pathology. Look, so what does this mean in English? It means that, from a practical perspective, usually the ejection fraction is less than 40%. Usually, again, this referring specifically to a non-ischemic pattern of cardiomyopathy. And so it's not reduced yet from infarction or ischemia. And usually with this, there's increase of mass and volume, usually associated with eccentric LVH. And instead of normal wall thickness, and there can be a variable degree of RV involvement, which we can discuss a little bit later on in this talk. So in terms of the incidence of dilated cardiomyopathy, it's actually, when I was reading and reviewing the literature, it's more common than I had previously anticipated. So in the US, between 2017 and 2019, the estimated prevalence is about 1 in 845 patients. And certainly there are certain risk factors and subgroups of the population that we see increased risk incidence in. And those are elderly patients, males, African Americans, and globally, dilated cardiomyopathy is seen in higher prevalence in the tropical and underdeveloped nations, probably because, in the tropics, there's an increase in certain infectious etiologies that can cause dilated cardiomyopathy, such as Chagas disease. And in underdeveloped nations, there can be a lot of nutritional deficiencies that can lead to dilated cardiomyopathy. And about half of these, there's no obviously identifiable cause, so we'll call it idiopathic dilated cardiomyopathy. And believe it or not, it is the most common cause of, most common indication of cardiac transplantation across the world. And when we actually break it down to specific causes of dilated cardiomyopathy, this is by no means an exhaustive list, but as you can see, it's quite a long list. So a lot of things that you can imagine can cause dilated cardiomyopathy, ranging from toxins to medications like chemotherapy, nutritional deficiencies like thiamine, and in endocrinopathies like hyperthyroid, infiltrative like hemochromatosis, amyloidosis, and there's a bunch of other sort of miscellaneous causes like LV non-compaction, pericardial cardiomyopathy. So the list is exhaustive. So when we look at the mortality of dilated cardiomyopathy, some of the causes of dilated cardiomyopathy actually have mortality almost as high as some of the terminal cancers. So it's quite a poor prognosis. But as you can see from this graph, this is a relatively well-aged, middle-aged study. And you can see that when we look at the different causes of dilated cardiomyopathy, they're associated with vast different clinical outcomes. But despite this heterogeneity, there's one common thing that they all share. And anyone guess what that is? They all need an echocardiogram. So therefore, we'll all have jobs. So this is actually from the most recent heart failure guidelines from HA. That they actually specifically mention in the text that a comprehensive TTE is the most useful initial diagnostic test, given the vast amount of diagnostic and prognostic information provided. So it's a bit of a ego boost for us. So what are specific questions that we when we look at these patients that we need to address on the TTE, the first question is really, is the LV preserved or depressed? Is the LV structurally normal? And lastly, are there potential hints to the causes of the abnormalities? So to do this, I propose a very basic framework of echo evaluation of dilated cardiomyopathy. I think a really good 2D evaluation or a really good echo evaluation of DCM should include at least these followings. So in terms of 2D quantification, we need to describe the chamber geometry, chamber dimensions, and when possible, provide volumetric assessment to get a more detailed understanding of the chamber size. And then we proceed to systolic function, looking at wall motion, EF assessments, and if possible, being strain, and then followed by diastolic function, evaluation of the valves. In dilated cardiomyopathy, the valves of interest specifically are mitral valve and tricuspid valve, to understand whether there's any primary valve pathology or whether there's any significant secondary valve changes that causes regurgitation. And lastly, looking at pericardium, effusion, and masses, those kind of things. I think overall, this is a pretty standard protocol that we all sort of intuitively follow, but I'm just putting my thoughts on paper here. So I'm going to briefly talk about chamber quantification guidelines, or selected portion of the chamber quantification guidelines. This is a huge topic that I think warrants a specific 1 hour talk on, so I'm not going to go into too much detail about it today. But first, when we look at LV dimensions, there are a couple of different ways we can use to measure LV dimensions. In terms of the linear dimensions, the two common way we often assess is by sort of using a snapshot of the LV in peristernal long axis, measuring the LV inner dimensions in systole and diastole, as well as using M mode. So the 2D linear dimensions, the measurements have certain advantages. The advantages are, it's easy to perform, and because peristernal long axis is usually one of the first views we perform on the TTE, and immediately we can get a sense of the LV size. But the disadvantage is that in a lot of these dilated cardiomyopathies, there's significant shape distortion to the ventricle. So measuring the ventricle size at the base, which near the mitral annulus, really is not reflective, or may not be reflective of the overall LV size. For the junior trainees on the call, when we're doing these echoes on call, it's important, or when we're reading this echo in the lab, it's important to make sure that when we measure the septum, we do not include any of the RV trabeculations, which is one of the common causes of overestimation and of the septal thickness, and the posterior wall, to make sure not to include the cords. In general, a rule of thumb, in most cases, they should be relatively similar in thickness. Obviously, there can be asymmetrical septal hypertrophy. And usually the posterior wall is thinner than the septum, and general rule of thumb is that it should not be thicker than the septum unless there's specific posterior wall pathologies. If posterior wall is thicker than the septum, then probably we'll have to look carefully to make sure we didn't include the cords. And other sort of comment about this measurement is that it should be performed at the in the peristernal long axis, so perpendicular to the LV trajectory at the level of the mitral valve. And the other way we can do it is through M mode. So again, this is M mode through the LV using the peristernal long axis. This is easy to perform as well. Again, gives us a rough estimation of the LV size. But the problem with the M mode is that we may not be exactly perpendicular to the LV, so it can lead to over or underestimation. Of course, one of the best ways to assess for LV volume assessment is through volumetric assessment using symptoms biplane. The reason why this is more accurate than the 2D is because it corrects for shape distortions, and the disadvantages of using symptoms, as we all know, or I've all encountered, is that oftentimes we can foreshorten the apex, and sometimes we get really poor endocardial definition, just because of poor acoustic windows, and that can be hard to trace a Simpsons. And just another comment about Simpsons, when I was first learning echocardiogram, I honestly thought Simpson's was just an average of the 2-chamber and the 4-chamber EF, but it turns out it's actually, much more complicated than that. So we essentially contour the LV and divide the LV into a series of discs, and is actually a summation of all the volumes of these discs, 20 discs, I believe, in total, that gives the volumetric assessment of the LV. That's why when you sometimes do the 2-chamber EF and the 4-chamber EF, and then your overall result is actually not an average, direct average of the two results. So that's something to keep in mind for your junior trainees in the room. So how do we solve the disadvantage? Well, how do we improve on the 2D Simpsons? Well, that is with the use of ultrasound enhancing agents. There are a couple formulations commonly used in a variety of clinical practice. Definity is the most is the one that we hear use, but there's other options. The idea is mostly the same, is that it's some sort of an internal gas surrounded by a phospholipid membrane, and you inject this into the bloodstream, and the gas reflects ultrasound beams and therefore enhances the cavity. And so when we give these LV volume, when we give contrast or ultrasound enhancing agents to the patient, we can see that we're able to delineate the endocardial border in greater detail than unenhanced images. Because of this, the volumes estimated using echo contrast on 2D imaging is slightly larger than we normally would get from just a regular unenhanced 2D Simpson. There's really no good guidelines yet on mild, moderate, severe dilatation based on volumetric assessment using echo contrast. So the two cutoffs that the chamber quantification guidelines or the contrast guidelines give us are 98 mils per meter squared for LV-EDDI for male and 83 mils per meter squared for LV-EDDI for females. So really it's a dichotomous dilated or non-dilated. If it's above these, we call it dilated LV. If it's below this, we'll just say it's normal size. But hopefully with future updates to the chamber quantification guidelines, we'll actually have a more separation in the different gradings of the LV size based on contrast volumes. Of course, the most accurate way we can assess LV size is through 3D volume. This may not be available in all labs. Certainly here we have 3D probes, and we use these for oncology cases where chamber quantification is of utmost importance and guide therapy management. The advantage of this is that there's again no geometric assumption of the LV, and it's really unaffected by foreshortening, and is more accurate and more reproducible compared to 2D species. And the disadvantages is that to do 3D assessment, you need a certain temporal resolution, and you need a certain image quality for the software to be able to pick up the endocardial borders. And certainly if the image quality allows, the 3D LV volume assessment using a 3D probe is more reproducible and is much more comparable to volumes obtained on cardiac MRI. And there are multiple studies looking at 3D LV volumes. And the 3D LV volumes tends to be, again, a little bit bigger than the 2D volumes that we normally get from 2D Simpsons. And the cutoffs here for upper limit of normal for men is 79. This is indexed LV-EDD. And the cutoff upper limit of normal for women is 71, whereas for 2D volumes, I believe it's 74 and 61. And I put this up as a reminder that, chamber sizes can vary vastly between different ethnicities. And here we have multiple studies across different parts of the globe. And we can see that, Southeast Asians tend to have a bit of a smaller ventricle, probably compared to some of the sort of European populations. That's just something to keep in mind. And so we can see 3D volumes are very, very similar to volumes obtained using CMR, which is the gold standard for LV volume assessment. Okay. So that's enough about ventricular volumes, especially LV. So next we're going to briefly touch on determining LV function or ventricular function. So here, the first thing we do is looking at the LV systolic function. And when we look at systolic function, and especially we perform usually a global assessment followed by a regional assessment. A global assessment can be, performed visually or quantitatively using 2D Simpsons and also in 3D EF as well as sort of GLS. Again, the advantages and disadvantages of Simpsons and 3D EF, are similar to what I just mentioned. GLS, or global longitudinal strain, has become a relatively popular way of assessing global LV systolic function in recent years. Essentially, it uses speckle tracking technology to measure the degree of myocardial shortening during systole. And we do this in multiple views. And then the GLS is an average of all the different views. And the advantage of this is that, it's independent of the angle of which the images are acquired. The disadvantage, obviously, is that speckle tracking features are dependent on the vendor and the algorithm provided by the vendor. So then the overall reference values may be slightly different between machines to machines. And it's, again, dependent on image quality, because if you don't have a good, especially mid-myocardial definition, to track, the algorithm is going to screw up your string measurements. And in general, normal strain is about -20%. And the more negative, the better the LV systolic function. Okay. And here I've just provided the normal ranges for LVEF, just to remind the junior trainees that there is actually a slight different cutoff between men and women. Women, the lower limit of normal is 54. For men, is about 52. Okay. For 3D EF is about the same as 2D EF. Okay. Once we perform the global systolic assessment, it's important to then look specifically at regional assessments at the regional wall motion abnormality. And we grade these by the, whether the walls motions are normal, hypokinetic, akinetic, or dyskinetic. The reason regional assessment is important in dilated cardiomyopathy is that certain regional wall motion abnormalities can give a hint to the etiology of dilated cardiomyopathy. So if the regional wall motion abnormality fits a pattern of a coronary artery distribution, you may, more inclined to call this ischemia driven. Whereas, let's say if you have a basal inferior septal aneurysm, or if you that might be more consistent with sarcoidosis, or if you have an apical aneurysm with some thrombus, that might be more suggestive of Chagas disease based on the context. So it's important to look at regional wall motion abnormalities as well. And to complete our LV assessment, lastly, I just put a little slide up on LV diastolic function. Again, this is a very complicated topic, warrants a full talk on its own. This is just a cutout from the recent diastology guidelines, and the fellows in our lab, all of us discuss a lot of times about what to call or how to grade diastolic dysfunction. We all have different feelings about how to grade things, but in general, this is the sort of the flow chart that we follow. Grading of diastolic dysfunction is important in dilated cardiomyopathy, as I will present later on, because it's one of the markers of poor prognosis. That's why it's important to not forget this. Okay. So once we finish grading the LV, then we move on to the RV. The RV is a little bit of a more sentimental structure on echocardiogram. Because the RV is not a round shape, and depending on the cut on the echo, we can it's difficult to evaluate the RV because it's a crescent shape. So depending on the cut of the echo, you can over or underestimate RV size. So it's not really well imaged on echocardiogram. And to measure RV size, there's a couple linear dimensions that we can measure. Most common ones that we do here in the lab is the basal dimensions. Remember, it's inner edge to inner edge. But again, this is just a slice of a very complex 3D structure. And depending on how you orient your probe, you can really make the RV, as small or as big as you want. So that can certainly lead to under or overestimation. These are two other measurements we can perform to estimate RV size. I think most of this we do it visually. We don't necessarily measure it, like the RVOT diameter in the short axis and in the peristernal long axis. Certainly these, like I said, these we do it visually. We don't normally measure them because again, even though they're easy to do, they can vary vastly based on how you acquire the images. In terms of RV systolic function, there's again a couple ways. The 2D linear dimension that we commonly measure using M mode at the lateral annulus of the tricuspid valve measures the translational movement of the RV, which has good correlation with RV systolic function, and that measurement is a TAPSE. But again, this is not applicable in patients who we can see in this lab, and especially in patients who have had tricuspid annuloplasty or in certain TTVRs that can definitely affect the tricuspid annulus motion, so it will not be applicable in those. In those cases, then the next best option is to do a fractional area change where we trace the RV endocardial border, including all the trabeculations, the papillary muscles, or moderator band at end diastole and end systole to give you a fractional area change. But again, this is highly limited by image quality and also how the image angles are acquired. But it can overall give a good estimate of RV systolic function. Some of the more sort of novel ways we can use to evaluate RV systolic function is using RV strain. This can be performed with just the RV free wall strain, where an average of the RV free wall and the ventricular septum. And the cutoff for RV strain is similar to the LV strain at -20%. I think for research purposes, this is certainly being used a lot more than clinical practice. Okay. And briefly, once we finish the chamber evaluation, it's important to look at the valves. And valves of interest in dilated cardiomyopathy is usually the mitral valve. And when we look at the mitral valve, it's important to understand the mechanism of mitral valve dysfunction, is specific in DCM mitral valve regurgitation. There can be primary mitral valve pathologies involved, or most commonly secondary mitral valve pathologies, such as sort of ventricular functional MR that we commonly see in dilated cardiomyopathy. And when we quantify the mitral regurgitation, again, this is a very complex topic deserving a talk on its own. So I'm just putting here just a flow diagram of how to quantify MR. Essentially, it's really a combination of both qualitative approaches using visual estimates, jet areas, and semi-quantitative approaches like vena contracta length, pulmonary vein flow patterns, CW velocity shapes, and density, and sort of quantitative measurements such as PISA and regurgitation volumes. For those studying for Royal College exam, our group has come up with sort of a mnemonic to measure to remember echo findings for some selected echo findings of severe MR. If you ever get asked about what are echo findings of severe MR on exam, you just say 4, 5, 6, 7. Well, you're annoyed by the question, but it's, how you remember it is, well, EROA of 40 millimeters, okay, regurgitant fraction of 15%, regurgitant volume, RV volume of 60 mil per beat, and vena contracta of 0.7. You can apply this to AI and TR, and it's all ERV, and the numbers are slightly different. So you just ERV a couple of times, and hopefully, just remember the numbers. If you remember 3, 4, 5, 6, then I can't help you. So, so that being said, let's just delve into what are specific findings that we can see in dilated cardiomyopathy. Well, the first thing is, as the LV dilates, there's the LV volume increases, and there's actually a change in geometry. The LV takes on a more spherical shape. There, in the older literature, there's something they can use called the sphericity index, just describe how round the LV is. It really is a measurement of the LV diameter divided by the LV long axis ratio, and the reason why LV becomes a more spherical structure, it's just physics. If in a tubular structure, the LV, when there's increased LV size, there's increased wall tension applied to the LV wall. And if you have a tubular structure, the wall tension is really distributed in only one plane. So your tension is actually quite high. So when the LV remodels, it adapts into a spherical shape. So then you have more planes to distribute the wall tension. And then that is the purpose of that is to reduce wall tension. And so why is this important? So this study is older than I am, but it just tells you how, tale as old as time, right? Since the early days of echo, we've been using this to evaluate dilated cardiomyopathy. So in this study of 7 patients or 29 patients, very, very small study, it probably won't get published based on today's standards. If you have LV dimension, the bigger the LV dimension, the worse the patients did in follow-up. I mean, that's kind of, it's very intuitive, right? The bigger the LV, the more they get into heart failure, more they get into rhythmic complications. And interestingly, the more spherical your LV becomes, so as your diameter approaches your length, then they have worse outcomes. This is probably really just a reflection of more dilated LV gives you a worse outcome. Okay?
So by Pam Douglas, who later became the ACC president.
Oh, I did not know. That's good to know. Very famous person. Very famous person. And then the next important thing is the decrease in the LVEF has significant implication in the outcome of patients with dilated cardiomyopathy. So this is a study looking at outpatients who have dilated cardiomyopathy and follow-up and who have serial echoes, and they're stratified patients based on their LVEF. As you can see, the patients who had the worst EF, who had the lowest EF, had the worst prognosis. And one of the other things when we look at LV systolic function, this is an interesting finding in dilated cardiomyopathy. Maybe, Gina, this is so to give you a little bit of context, okay. This is a PW of the LVOT. Yeah. So what are we looking at here?
Variable tracing.
Correct. So exactly. So you got it. So this is essentially a Doppler evidence of pulseless alternates, right? You have alternating cardiac output between each cycles. And this is seen essentially in end-stage dilated cardiomyopathy or end-stage really profound LV systolic failure. And there's actually studies looking at patients who have these pulses alternates on Doppler and on hemodynamics. And again, they did much worse. So mechanical alternate, they did much worse than patients who did not have this finding. And in terms of diastolic dysfunction in dilated cardiomyopathy, a lot of these patients will have significant elevated filling pressures, and they will have severe diastolic dysfunction manifested by a restrictive pattern of filling. And when we talk about restrictive pattern of filling, it's really we're looking at a mitral inflow EA ratio greater than 2, and a mitral E deceleration time of very short deceleration time of 150 milliseconds. The reason why this happens is that as you approach higher filling pressures, when the mitral valve opens, there's rapid equalization of left atrial pressure and left ventricular pressure. So most of your filling is immediate and it stops because the pressure gradient disappears. So you have this rapid filling of the ventricle, and then as you move towards end diastole, the ventricular pressure equates to left atrial pressure, and if in cases actually slightly exceeds left atrial pressure, which is why your atrial contribution in your diastole becomes very minimal. That's why your EA ratio is greater than 2. And because you have this rapid filling and rapid stop of your early diastolic filling, that's why you have a quick deceleration time on the E velocities on the mitral inflow. And the reason why this finding is important in dilated cardiomyopathy is that, again, this is a very seasoned study, but good study that people looked at echo findings in patients with dilated cardiomyopathy. Those with low EF and those with a restrictive filling pattern did worse over 3-year follow-up with quite high mortality of 40%. Okay. And next findings of dilated cardiomyopathy is, we talked about LV systolic function, LV size, LV diastolic function. The next thing important is the correlation of RV function in dilated cardiomyopathy and outcomes. So when LV fails, the pressure inside the left side builds up, and that left side pressure is transmitted back onto the right side, causing RV failure, which is why the common teaching we get in medicine is that the most common cause of RV failure is LV failure. And certainly there's implications in patients who have dilated cardiomyopathy and have worsening RV function. This is a study looking at, again, patients with heart failure stratified based on their RV function and their PA pressure. We can see that those in group 4 with high PA pressure and low RV systolic function did worse in terms of their survival compared to patients who had normal PA pressures and normal RV function. Again, this is probably a marker of end-stage left-sided failure causing, a poor survival. And lastly, just briefly touching on the degree of mitral regurgitation in dilated cardiomyopathy. This is a study, one of the earlier studies looking at a correlation between the degree of functional MR and functional PR in dilated cardiomyopathy and their outcomes. And we can see that patients who had dilated cardiomyopathy with a severe functional MR did much worse than people who have none to mild functional MR. Again, the reason this happens is that as the LV dilates, there's the PAP muscles gets displaced more apically, and we tether the mitral leaflet more apically and causing a coaptation gap and result in secondary MR. And fortunately, now with modern technology like mitral clip, and we can reduce the degree of MR and improve patient outcomes. But once again, the MR is really a symptom of profound LV dilatation, LV dysfunction. And so there's probably a sweet window where we can treat the MR, improve patient outcomes, and anything beyond that is really just a symptom of end-stage LV dysfunction, LV systolic dysfunction. That may be too late for intervention. Okay. So in summary, dilated cardiomyopathy evaluation using echocardiography requires a careful stepwise approach, which I think we all do, but it's important to discuss these and putting them on paper so we all understand the importance of why we do all of these things. And some of the poor prognostic features on echo include increased sphericity index, Doppler alternans, worsening diastolic dysfunction, worsening RV function, and with pulmonary hypertension and worsening functional MR. And briefly, some of the future directions to improve on the current modality is, again, using 3D echocardiography as this becomes more common with increasing availability of 3D probes. This gives better evaluation of LV volumes and LV systolic function. And use of GLS, there's now research into using GLS to predict arrhythmic events in dilated cardiomyopathy. There's actually some good correlation evidence between areas of decreased strain and areas of fibrosis on MRI. And so people are kind of using this as a quick tool to predict arrhythmic risk in DCM. So I thought that was quite exciting. And that being said, that is my quick evaluation of DCM and echo.
So questions? All very quiet this morning. Yes, go ahead.
I have a question, but kind of the index volume for the LV with contrast. It's significantly high. Like it's almost the cut for the female is 84. So the cut without contrast 80 is like severe. For male is 98. This is the index. The index for male more than 100 is severe. So don't you think it's like?
Yeah, so I think this is, so I think the contrast guidelines came after the most recent chamber quantification guidelines. So I think there probably will be updates regarding the quantification guidelines. I think the next upline guide update probably will include contrast volumes and 3D volumes. That's what I think the field is going. I'm too junior to know what's going to be on the guidelines, but I suspect that's probably going to be the case. Yeah.
So happy to report that the Canadian Society of Echo last year has awarded a great grant to Dr. Howard Leonpoy and Dr. Wendy Zhang, who will actually investigate this particular topic of normal volumes with echo contrast. So we keenly look forward to the interim reports as well as the final report in the upcoming CSE meeting in April. This is going to be held in Montreal. That's the answer to that.
So it's coming.
Yeah, it is. Well, because all the chamber quantification guideline was actually done like a lot of the contrast work. So, it's actually very interestingly that it is one of the like missing piece, because right now our problem is that when we trace and report the volume, we don't specify whether it's 2D or contrast. So it's actually very important for us to specify when we trace the volume, which one are you tracing? Are you tracing with contrast? Are you tracing with 2D? Dr. Kim. You have a question?
Of the
You're falling off the bridge.
I haven't.
Okay, any other questions?
I haven't enough.
Well, our video is not on, so you may not be able to see it, right?
Oh, yeah, okay.
So now you can turn it on.
Return?
There you go.
There we go, okay, there we go.
The cut for
Say hi to the audience.
the cut for ejection, like it's less than 40, some less than 50. The average, like for the male is 52, for the female is 54. Some of the, maybe you see it in the chamber quantification, they said 53 is the cut. Below that, it's, how can we approach such? Do we need to remember all the numbers, or do we just put them?
Well, 53 is the number that is used universally as the lower limits of the cutoff based on the 2015 chamber quantification by guideline by Lang et al. So that's the number that we remember, and that's the number that American Society of Echo has used to harmonize all the other guidelines. Because there were some challenges at some point that different guidelines writing group in ASE, ACCHA, they use different numbers. So, for example, they had to harmonize the chamber quantification guideline as well as the cardio-oncology guideline to make sure all the numbers are the same. Otherwise, it gets really confusing. So that was an issue before 2015 when people realize you have to remember like 50 for something, and also with the ACC, AHA, valvular heart disease guideline, there's also another number at some point, but now they're all harmonized in all the updated versions. Then the bottom line is that all these guidelines, they're not like God didn't actually write down in the commandments down from the Mount Sinai to tell us exactly what the EF is. But the bottom line is having these guidelines is to make sure that at least something to follow consistently. So it's more for comparison, so that internally within the lab, that all the things are, consistently over time. So you know that the person is falling off, dropping off, or they're really normal or really abnormal. I mean, for many of you who may not have entered the field yet, but up until about 20 years ago, there was no guidelines on ejection fraction, LV mass, LV volumes. All we use is actually the back of a textbook of an index. So there's a few textbooks out there. So Feigenbaum has a standard table in the back, and Dr. Wayman is one of the ones that many people use, and Mayo has their own. The Wayman's lab was actually quite interesting, just historically. He recruited 100 colleagues, like sonographers, medical student residents, male more than female at the time, and start measuring them and actually reported that particular set of numbers that has been used like for the longest time. But then again, each lab depends on where you train, you will use a different set of numbers. So we actually within the city of Toronto, for example, if you go to lab A in Scarborough versus lab B in downtown, the normal can be completely different. So these guidelines serve to actually try to harmonize everything. And as many of you know, the ASC has sponsored the World Echo Standards paper that Dr. Wendy Zhang is our Canadian representative, who actually presented the new set of numbers that sort of got into around the time of the 2015 chamber quantification. So that's the spirit of the guideline, and the numbers are not necessarily God sent. I wish they were, but they didn't. Like God didn't actually create us with a menu. That would be actually quite useful. A user manual, same thing as a parent. I'm looking for the user manual for parents. They don't come with the kids, unfortunately. We have to discover them as we move along. For parents in the room, they would understand what I just said. Any question? Many of these things come from historical reasons, and many papers that Dr. Cai just presented were actually very historical. One of the things that if you enter the field like more recently, you know how powerful echo was. But for many, many years, when echo first came out, we were not so well respected because there are a lot of prognostic data that came with it. The first set of prognostic data that echo can say, no, I can predict the outcome was actually from Dr. Alan Klein, who's actually Canadian from Montreal. And he went to a Cleveland clinic and came up with the E to A ratio and the short deceleration time to look for prognosis for amyloidosis. That's one of the first paper that actually looks at prognosis. And then subsequently, the paper that you presented were the follow-up papers that they did all the prognostic outcome. And one of the unique features of Mayo Clinic is because they live in Olmsted County, and they actually have one of the first outcome data within North America. So the people are very smart, and Mayo corroborate with their echo data and their Olmsted County survival data to be able to come up with all these papers that Sean, many of them were from Mayo originally. But Canada now has really good outcome data as well from our public health database, so we can do some of these in a much larger scale, even bigger than Mayo, if we do it. So a lot of it, this history that you actually have presented behind all these papers. That was the message. Okay, thank you.
Thank you.